Now, joining me to host this Tell Me More About session is my scientific co-host of tonight, Helena Franciscu. Good evening.
Good evening, Brett.
Good to have you on my side. You are an assistant professor at the University of Lisbon in Portugal. You work in your private practice and you're part of the EAO Education Committee. So let's kick it off. What are we talking more about tonight?
So tonight we have a very interesting topic, and I'm sure that people at home are going to have a lot of fun. So today we have the topic of lateral ridge augmentation, autogenous versus allografts. So for that we have a very special guest. Our guest comes from Germany. He's a very experienced surgeon. He is also an assistant professor and research fellow at Cologne University. He is also a member, active member of the Aesthetic Academy, European Aesthetic Academy. He is also an ambassador for our EAO. He lectures worldwide on bone regeneration, immediate implant placement, and soft tissue management. Please, a warm welcome to our guest, Arndt Happe. Thank you.
Wow, Arndt, good evening. And let me quickly remind you that this is live. You can send in your questions via the panel on the right side of the screen. And in the second half of this session, we'll try to see if we can also take some of your questions for Arndt Happe. So, Helena, Arndt, you're up.
So, Arndt, I know that you were trained at Curie's clinic for autogenous bone grafts. Are you using allografts in your daily practice? What is your experience?
Yes, thank you very much. First of all, thank you to the EAO for the invitation, of course. It was an amazing event. Yeah, that's right. I was trained at Professor Curie's clinic, and I'm a big fan of autogenous bone grafts, of course. But for some patients, I started using also allograft because you try to develop your own techniques, and for some patients, you need special techniques. So almost 10 years ago, I started with using allografts, and I'll show you one case where I started from. You know, this is, you see on those pictures, this patient, she suffered from a severe periodontitis. She was treated for the periodontitis, also ortho. She's partially edentulous. And take a look at the lower jaw. It's a very narrow ridge. And if we take a look at those CBCT scans, you see this very poor bone situation where you don't have a very good regenerative potential of the residual bone. So usually I would like to go for autogenous bone, but for this lady, we used allografts, and I used them like in a split mouth design, two different products actually. You know, it's a freeze-dried bone, but you have different protocols of processing this bone depending on the company. So this is product A and B, as you may like, and you see I fixed these blocks with screws, and then you cover them with a collagen membrane, as usual in GBR, in order to prevent the soft tissue from growing in. And you see the outcome after 7 months. So we went back to the case after 7 months, and here you see the CBCT scan, and you see how nicely this came out. Also the clinical pictures here, you see some resorption on the right side of the mandible. You see it at the heads of the screws. The other side looks a little bit better, but I was able to place appropriate, like say, implants of appropriate size in this patient. And I think the result was really nice. And I was really astonished because I was a big fan of autogenous bone, of course. So this has a great potential, obviously. We can talk about some other issues like infection, transmission and stuff, and also immunologic involvements. But here you see the patient as she was restored in May 2014. And also we have a nice, this is before and after, by the way, where we started from, so nice transition. I have to say, let's say a nice change. And this is the 5-year follow-up. So you nicely see how the bone stays at those implants. They have a machine color of 1.4. So this is a pretty nice result, as you can see. And you have traditional sinus grafting in the upper jaw.
Very nice case, Arndt. So how safe are allografts?
Yeah, you know, it's not deproteinized. We still have proteins in those allografts. But, you know, I was a little bit critical, first of all, but then I saw in orthopedics, they use like 30,000 allografts a year in Germany, and it's widely used in the US. So I started off with a product that comes from the Cell and Tissue Bank from Austria, and it's from patients who undergo hip surgery. They get a tap, and the femoral head is cut off. and they agreed to this to like donate this bone. And this is a different story if it comes from another, like a tissue bank, like in the US. So we have some products that we are able and allowed to use in Europe, actually.
Yeah. And what's the evidence on allografts? What are the outcomes? And when I mean outcomes, I mean implant survival rates.
Yeah. If you go to the literature, there are some nice studies. Maybe we can have those picture again, and we go one back. We have to differentiate. There are different kinds of allografts. We have freeze-dried bone allograft, we have demineralized freeze-dried bone allografts, and we have fresh frozen bone allografts. And I usually use the first one. This is the one we use in Europe, and the other ones are widely used in the US. And between those products we have on point one, there are also different kinds of processing methods. So if you read the literature, you have to really take a close look on what they're reporting about. But if we take a look at the key messages of those three systematic reviews I mentioned in the lower, we know that these allograft blocks, they are a reliable alternative to autogenous bone block grafts for augmenting the atrophic ridge. And we also know that the survival rates of implants, they are pretty similar to those if you install implants in autogenous bone. And they have comparative studies and they have non-comparative studies. And in the comparative studies, they showed that they revealed no statistically significant difference in implant treatment outcomes between the two methods if you compare autogenous and allografts. And in the non-comparative long-term studies, they demonstrate high implant survival, gain in alveolar ridge width, and bone regeneration after horizontal augmentation with allogenic bone blocks. But I would like to mention that you can also read on those reviews that they have quite some complications with dehiscencies and stuff. So this is not a solution for a non-skilled surgeon. It's also very demanding to use those materials, of course.
Okay. So how stable are these grafts?
Let me first show you some insights of one review from Monnier. And they took a look at 360 bone blocks and followed them up for 4 to 9 months. And they had a failure rate of 2.4%, which is pretty low, I think, after 1 to 2 months. The weighted mean they augmented was almost 5 millimeters, which is pretty much comparable to the results we have with autogenous bone. And also the survival rates, weighted mean was 96.9 from 228 implants. So this is quite a big number of treated cases, and the mean follow-up was almost 2 years. And about stability, as you mentioned, we have, you see, the reviews we have are on blocks, not on particulate material. And this is also on blocks. And they compared autogenous bone blocks with allogenic bone blocks. And you see here on this picture on the right that it's pretty much the same outcome after 12 months of follow-up. And the overall shrinkage amounted up to 13 to 14% and was not statistically significant difference from each other.
What about histologically? What can we expect from histology? You showed us a beautiful case. It looks like bone, but what is inside?
Yeah, this is a good question because we changed the concept when I was trained as an oral surgeon. We used to use blocks from the mandibular ramus, and then we developed the Curie technique in his clinic because we wouldn't want to augment a solid cortical block because of the lower rates of turnover. And if you take a look at those blocks, these are 14 patients in this study where they took a look at the histology of those mandibular bone blocks. And they showed the typical pictures. You have vital bone, you have necrotic bone, you have soft tissue, and the amount of vital bone was 27.5. And if we take a look now at those allografts, and we have again the two different products that I showed in the first patient. This is the same product in the study, allograft A and B. And you see all the signs of remodeling. You see new bone, you see necrotic bone, and you see osteoclastic activity. And between the two allografts, you see here the new bone amounted up from 27 to 41, depending on the product. But I have to say, you can hardly compare it, because it's different if you make an augmentation with cancellous bone or cortico-cancellous bone, and it's dependent on the individual. So it's really difficult to compare that, I have to say.
So, and in your opinion, what are the key factors of success when using this type of materials?
First of all, if you take this from a package, from a blister, then it's freeze-dried. You have to rehydrate it, otherwise it's not biocompatible. So this is really important. And I would like to show a case where you can see some of the crucial things. And again, this is a patient who lost an implant. I'll show you another case later, maybe. She lost an implant before, and she was, critical towards augmentation and scared. And you see this critical defect here, three-dimensional defect with a vertical component. And I would like to show a video where you can see how I approach this. This was too fast, I'm sorry. So I start with a crestal incision, and it's a typical incision design. You need the same skills with autogenous bone and allograft, that's for sure. So it's not an excuse for poor surgical skills to use an allograft from the blister, because you can't harvest bone. So you need surgical skills, you have to be well trained. And maybe it's even more difficult because you have a lot of material you can augment. It's much easier to take it from a blister than to harvest bone. So you have a big amount of bone, maybe. So this is used here in GBR technique, so this is not a block. You can use those materials also as particulate material. So I like very much the GBR technique, because the blocks sometimes are difficult to attach, they can break, and also they are spongeous bone, cancellous bone, so sometimes they undergo more resorption, and these materials is a mixture of cancellous and corticocancellous bone, particulate, and you see here how I cut the periosteum to release the flap, and now we have a tension-free flap closure, and then the suture technique is also very important. I go here with 5O material, monofilament with a mattress suture in order to have an intimate contact of the flap, and then on top I use microsurgical sutures 6O. Okay. And this is a CBCT scan before and after. You see how nicely the bone came out. We gained a lot of volume, but what's more interesting now is how looks the bone when you get back to the case. Now after, I think, maybe 6 months. And we open the flap again. It's a full thickness flap, of course. And whenever we talk about bone augmentation, I forget to mention this, I try to omit releasing incisions. Right. So when I get back to the case here, again, no releasing incision. You see there's some remnants of the membrane. Mm-hmm. The membrane I used was a partially demineralized cortical bone, porcine bone actually, and there's still some remnants here we remove. And now you see how nicely the bone comes out. You see all the clinical signs of remodeling. You see bleeding, and you don't see any white bone. If you start drilling in the bone, it's really dense, it's hard, and it's really bleeding from the bone. So this is perfect bone augmentation result, I have to say. Yeah, now you go for the typical drilling protocol, of course. So we can shorten this, I think, a little bit, but you clearly see how nicely this comes out, and we also saw the histologies. So as a strong believer of autogenous bone, I was really very surprised how nice these materials work. So here is the rehabilitation that the referring dentist did. Yeah.
Very nice case, and with really a really nice result.
Exactly. Helena, we have audience questions. We are deep into our session, so let's at least make sure we take one.
Yes.
It's Mikhail Petrov, I think I pronounced that correctly. He goes back to the title of our session about autogenous versus allograft, and the question is there any difference on the management? It's a rather broad question, but on the management of both materials.
I mean, of course, harvesting the bone is of course
okay.
very
so that's
demanding
in the initial
thing.
phase.
Okay,
yeah.
So this is time consuming, and it's you have a second donor site. So okay, we don't have to harvest bone. It's a big issue, of course. But if you use those materials, I mean, it's not very much different. Of course, if you have a mandibular block, from the ramus. You can nicely attach it. If you have a cancellous block, this is more brittle. It's difficult to really screw it in place, and it may break. So you have to be very gently if you work with it. And also rehydrate it, of course. And if you have a block, it's not very easy to rehydrate it. You can use a syringe with sterile solution and then make, how do you call it, a vacuum in order to extract all the air from the block. Because usually it's not very easy to get the sterile solution inside and to really rehydrate it. So this is really a difference.
These are some of the new challenges when you start working with allograft.
That's true, yeah.
Exactly.
Interesting.
So for the people that are watching at home, if tomorrow morning they have a patient for a lateral ridge augmentation, which technique they would choose?
That's a good question. Usually it's like in the natural surgical world. I mean, you can use a block. If you like to work with blocks, you can use a Curie technique. And I show you one more case where I used this Curie technique because we developed everything to this kind of technique, and you can use it for lateral, also for vertical. And this is a very demanding case because it has a vertical component. And again, this is a lady who lost an implant in the aesthetic zone. And if you lose implants or you have to explant implants, often you end up with really difficult defects, and especially in the aesthetic zone, this is quite demanding. So what you see here is a defect, a class 5 defect if we go back to the classification from Benich and Hemmeler. So vertical component, there's no palatal wall, no buccal wall. And in these cases, I like to use the Curie technique. So I reconstruct the palatal wall, the buccal wall. And you can use now autogenous bone. In this case, I used a xenograft. This is porcine bone, which is partially demineralized. You can also use allograft plates. But it's important what's inside, because the plates are far away from the implant. So the filling of this is really important. And in this case, I used an allograft again, because this lady was a little bit traumatized. She underwent some surgeries. So we tried to keep the morbidity really low. And you see here how I did that. So the typical Curie technique, I filled it with the allograft. I rehydrated, I mixed it with blood, and then flap closure is really difficult. This is really difficult. Yeah. It's not depending on the kind of material you use, but you have to be really trained. And you see how it comes out after. I think this is wrong in the presentation. I think I waited here 4 to 5 months because it was a vertical case, and on one slide it's written 3 months. That's wrong. You see here before and after in the CBCT scan, a nice volume that we gained, and also if we measure this, I gained almost 1 centimeter, 10 millimeters of bone on the palatal side. So I was really happy with this result, and I was able to place the implant, and we let it heal again. Then on second stage, I tried to improve the soft tissue management again, very important for bone augmentation, also after bone augmentation. And the case came out really nicely, and these are always or have been cases that really gave me a headache. And today I have nice techniques with autogenous bone, with allografts. And in my hands, I have to say, I'm sorry to say that these grafts, they perform like autogenous bone. I was really surprised, but we have to say there are some issues because it's from another human being. And we have to discuss this, and I know it's not allowed in all the European countries.
Of course.
So, well, with that, Arndt, I think you're opening up a topic that we could do an entire tell me more about on. But 20 minutes fly when you're having fun. They're literally already gone. So, Helena, if you are listening to Arndt, all the different topics, the different cases, what is the most important thing you take away from this session?
First thing, I have to congratulate Arndt for the wonderful case that he showed us. So for me, the take-home message is allografts can be used when it comes to lateral ridge augmentation, and implant survival rates of implants placed in these type of grafts are very high, comparable to autogenous bone grafts and also to healed ridges. And I think this is the main point of the session.
Interesting topic, and we would love to talk more about. But time is up for this Congress. Thank you so much, Arndt Happe.
Very much.
Thank you, Helena Francisco, for kicking off, and thank you for your questions so far. With this, we come to the end of our first scientific session of our evening.